All right, we're back. Okay, so last time we were together, we worked on the pectoral girdle and the pectoral limb. The reason why I'm stressing pectoral is because we have to make sure we separate that from the pelvic girdle and the pelvic limb. That's where we're going today. So we're going to go down to the pelvis and then we're going to go down the leg. So again, I'm going to follow the PowerPoints just like I've been doing thus far. So we're going to start off with the innominate. Innominate just simply means one half of the pelvis. The pelvic region is actually composed of three separate units. Two innominates, the innominate on each side, which we'll talk about right now, so the innominate, right? Then we will also talk about the sacrum as part of that unit. The sacrum, though, is not part of the pelvic girdle. It is part of the pelvis. Remember, three separate units to make up the pelvis. Two innominates, one on each side, and the sacrum. That makes up the entire pelvis. But the sacrum is not part of the pelvic girdle. It is part of which area? The axillary skeleton, exactly, because remember, these are separate vertebrae, right? Those are separate vertebrae. These are sacral vertebrae, so that's part of the vertebral column. So that goes with the axillary skeleton, even though it makes up part of the pelvis. And if we're going to talk about the pelvic girdle, you would assume that means the whole thing. And it is true. It is true. You should technically be talking about the entire thing because that entire setup is what holds the legs on, what gives you the foundation, the base of the trunk and everything above it. But because it's part of the spinal column, we leave that with the axillary skeleton. So we're going to just do the two sides of the pelvis. One side only, because why would you look at the other side? It's a mirror image of the opposite side. So we're just going to look at the pelvis from one side. The unit on that side is known as the innominate, right? This is an innominate, and you can see it on the PowerPoint, right? That's the one portion. I can grab another portion just to show you how these are not the same innominates, meaning they don't go together. But you can put them together like this. It makes up, that's the front of your pelvis. That's the pelvic canal. It's where the little baby goes through, right? And the sacrum sits in here, sits to the back, and creates that last little component. All right, so let's get back off of that. Let's go to the innominate. Starting off, let's talk about the bones that are actually involved in the construction of an innominate. Innominate is the entire thing, but it's actually three separate bones when you are a child, okay? So this portion here is the portion that if you are poking around in the front of your body, right below your belly, you're poking on this thing right here, okay? This is the pubic bone. So the pubic bone starts about here, and it goes all the way around to about here, okay? That is the pubic bone, okay? Boom, 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 up to about here. Then, if I turn it a little bit, we have this point where we stopped with the pubic bone, and it comes up, goes through the middle of this giant joint, and goes down around the back side all the way back to that other point where we stopped the pubic bone. Remember, the pubic bone stopped about here and about here, right? So everything going off this direction, this is all what we call the ischium, right? The ischium. This point right there, this big flat, or it's a bulged out area. We call it a tuberosity. It's called the ischial tuberosity. When you sit down on a chair or you sit on somebody's leg and you feel that bony, like somebody says you have a bony tush, right? You're sitting there and you can feel that bone digging into their leg. Or just when you sit on a hard chair, you can sit there and feel yourself just banging those two sides right on the desk. Or chair, excuse me. that's exactly what you're sitting on, right there. You're sitting on the ischial tuberosity. So that's that hard point in your tushy, okay? So from about here, okay, all the way down to here, right? Because this is pubis, right, or pubic bone. It can be said either way. So going up this direction, around to about here. That's the ischium. Pubic ischium. Then we have the big blade part of it, what we call the ilium, right? So let me get this back here, okay? So the ilium is everything from about here, right? That's where that pubic bone ended, right? Everything up here, all of this, the entire bladed surface is all ilium. So this stuff is all ilium, right? So let me flip it so you can see the acetabulum, or that big socket, which I'll talk about here in a minute. But basically from about here, middle part of the joint, the acetabulum right there, again we'll talk about that in a minute, from about that middle point, all of this, all the way going all the way around and back up into the middle. So all of that is ilium. Starting again in the middle portion of the acetabulum, right? Starting about the middle part. If we go off this direction, we're heading toward the pubic bone. If we were to start here and head off this direction, we'd be heading toward the ischium, okay? So basically the ilium, the ischium, and the pubic bone all meet up right in the middle of the socket, right? So the three coming across, and you'll see this in the PowerPoint, they all land right in the middle of this acetabulum, right there. Okay, again, that's the socket where your femur is going to articulate. That's kind of your hip socket, right, if you will. It's a ball and socket style of joint, right? I'll get back to that just 1 second. Okay, so that is the innominate. So let's talk about the features that we have for this particular thing, or that we're going to talk about anyway. All these bones are completely covered in features, right? But we're only going to talk about a few. And some of these, and most of them, are going to be useful for our later assessment of, in this case, it's going to be for sex and aging when we get to that section. So we need to find, if we're going to sex a skeleton, we need to find places that are different between males and females, right? Or aging, we need to see, how would you know if a person is young, middle-aged, old age? We need that to give our age classification. So we're going to look for a number of different details. The innominate is one of those places where we will find good aging material, areas where we can age very, well, at least reasonably accurately. In fact, the pelvis is the best area. One part of the pelvis that I'll talk about in a minute is one of the best areas for aging. And of course the pelvis, when it comes to male versus female, is hands down the most critical, because obviously women have to have the ability to give birth, so they have to have a pelvis that is wider, where the pelvic canal is larger and all that kind of stuff. So you see some very gross differences, male to female. So if you're going to talk about sexing a skeleton, the pelvis is going to be the area, and particularly the innominate, right? We're also going to talk about the sacrum in this, but the innominate is going to be your big one, right? So let's take a look at a number of features. Let's talk about them in the order they show up on the PowerPoint, okay? So let me rotate this around. Again, put this in proper orientation, okay? So we're going to put that in the body just like this, okay? That's how it's going to be. Remember, the pubic bone is in the front of your body. It's anterior. It's the part that you poke on when you're poking around below your belly, right? That's the part you're poking on. So we have the pubic bone here, yeah? If we turn it and we look at the medial element, medial point of the pubic bone, we get this surface right here, and I'm going to zoom in on that. All right. So we get this surface right here. That's called the pubic symphysis, right? The pubic symphysis is a fantastic aging area, and you'll see this as we get to that portion of the class where we're talking about aging and things like that. But that's the pubic symphysis. That is the point where the two innominate come together. So I'll just grab this and try to show you. Okay, there's the pubic symphysis on this one right there. You just saw the pubic symphysis on this one right there, and that's where they come together like that to create the front part of your pelvis, right? So those two pubic symphyses, boom, just like that. Okay? All right, again, that's going to be one of our aging areas. All right, another aging area is an area called the auricular surface, right? Auricular basically means ear-shaped, right? Ear-shaped. So we have the ilium, this big giant blade. If you recall, this entire area is all the ilium, right? We have this area right down here, okay? There is this area right here, right? This roughened area. I'm going to zoom in, but we have this roughened area here. It's ear-shaped is because it's basically, I don't know, ear-shaped, right? It's kind of semi-lunar, whatever you want to call it. Let me zoom in so you can see what I'm dealing with here. Okay, so it is this surface here, right? It's kind of hard to tell on there. Let me see if I have another. This one might actually be a better example. Maybe you could see it better. Okay, right there, right? Like this, okay? So, coming up here, right through here, up and around and back down. Okay? So, comes up here, goes like this, comes back around and down. This area here, ear-shaped, I guess is what they're saying. So the auricular surface, we're going to be able to use that for aging. Now that area is the connecting point where that's where the sacrum comes in, right? Remember our good old sacrum coming in right here. Let me zoom out just a little bit. Okay, so we have our sacrum here. If you look on the side here, you'll see that there is also an ear-shaped element right there. You can see that really clearly. It's very ear-shaped right there. That point is the point that articulates with the innominate. Okay, so bringing this in here, got the ear shape on this one, got the ear shape on this one here, and the two go together like that. So the two ears come together just like that. And that makes up that back end. That's where the sacrum is going to be attached. Okay. Alright, get rid of that. Okay. So go back over to this. Okay. Let's go back over to this. So we have the pubic symphysis here. We have the auricular surface here. Okay. Alright. Now let's go to the greater sciatic notch. The greater sciatic notch is that notch right there. This notch right here. That's the greater sciatic notch. Got a lesser sciatic notch down here. This notch that's like this. That notch is the lesser sciatic notch. This is the greater sciatic notch. Okay? If you look again, let's zoom out. Give ourselves a little more area. Okay? Go ahead and turn it like this. So this is how it would be sitting in the body, right there. If I were to take the pubic bone and let's just put it down, let's just rotate it in and touch it on the table, and I'd lift up, there's that greater sciatic notch right there, this giant notch right here. So it's on the posterior side of the ilium, correct? If I look inside the pelvic area, so now I'm looking inside to where your intestines are, there's the greater sciatic notch once again there. That's going to be a sexing element. We're going to use that to sex this skeleton. Okay, one of the areas we're going to use to sex it. All right, and the last thing that I'm going to point out, these are all going to be used later on, that's why I'm pointing them out, is the subpubic angle. So once again, pubic bone, right? All this being the pubic bone, all of that, right? The angle that is taken from a straight line that is drawn down from the pubic symphysis, so my pen is simply resting on the pubic symphysis right there. The angle that is taken between that pen, oops, sorry, there we go, and the lower ramus, this is the ramus here, right? The angle that is taken between that straight line and that ramus is the subpubic angle. So let me see if I can try to hold all this. So this angle here, right? So this angle here is an acute angle versus something like a very obtuse angle. It's a very acute angle right there, okay? Now that is the subpubic angle, boom, right there. Now that angle changes between the sexes. So this is a very tight angle, it's a very acute angle. I can take something more on the order of like this one, and let me show you what this one would look like. I'm going to have to reverse it because it's the other side of the pelvis. Okay, so now I'm going to do the same thing on this one. I'm going to put it right on the pubic symphysis, and now all of a sudden it's still obviously acute, but it is not nearly the angle. So let's look at that, and then I'll grab the same side this time. There you go. That. See the angle there? It's a very tight, reasonably tight angle relative to this one. Okay? So that's the subpubic angle. It's going to differ between the sexes. Okay? So that is what would be the posterior and the medial sides of this, other than the pubic symphysis, which is on the anterior side. It's on the anterior medial side, the front of the pelvis. But let's go to the last thing, which is, put it right there. You've seen it 100 times already since I've been flopping this thing all over the place. That socket is the acetabulum, right? The acetabulum. That is where the femur, hopefully, I'm assuming your femur attaches this way. The head of the femur, the ball, goes right in there. Okay? And that's your ball and socket to allow your hip to move, to allow your upper leg to move around. Okay. And that is going to be it. Okay? Alright, take the femur out. Now, the acetabulum can also be used to determine the sex of an individual. It's going to be very difficult for us, so I'm not even going to attempt it. But that would be also a very good sexing area. It's not only the size of it, but also the depth of it. It's going to give us that indicator. But again, I'm not going to hold you to that, but that also would be a nice sexing area. Part of the depth part, I can't show you. That would have been a good one. But as far as the size goes, the size of the acetabulum is going to match the size of the head of the femur. That makes perfect sense. So in order to determine from the size the sex, we could actually use the head of the femur. And later on when we get to that point, I will show you how to do that, because the head of a femur of a male is going to be larger than it is for a female. And we have a cutoff point. We have a point where we say if it's bigger than this number, then it's a male. If it's smaller than that number, it's most likely a female. And that, of course, would match up with the acetabulum. But really, the acetabulum, the key here is the depth of it. But you could also use the side. If you didn't have a femur, for instance, you could use the acetabulum. All right. So that is the pelvic girdle. It's just made up of those two innominate. That's it. Because remember, the sacrum is part of the axillary skeleton. So now we move into the pelvic limb, which is the leg. Okay, so if you again look at your PowerPoint, you see that the femur is the next thing. Of course it is. It is the largest bone in the body. I tried to turn the video the other day so that the bones are more oriented like they would be in your body. The only problem is when I did that, it made the image very skinny because of just how it converts this the rotation of the image by 90 degrees. It made this real skinny image. It's the same image, but it's just skinnier, and it was hard to see, so I chose not to do that. I chose to put it back into the normal landscape mode, which means that when I was showing you all the bones, they were actually sideways to you, which if you've seen the video, which I'm guessing you've done so, you'll see all the bones were explained to you sideways. That's simply because otherwise, if I made it as I was hoping I could do it, make them so it's more in the portrait style for you guys, it made it just too skinny. So in this case, I went back to putting the camera to kind of the landscape way, the way you would normally hold the camera. So I'm not going to be able to show you the entire femur in this shot right here, which would be what you would normally see. So for the full effect, I'm going to have to turn it, right? I'm going to have to turn it to its side, and then I'm going to have to do everything I can like this. And then what I will do after we've done all the major things, then I'll turn it and zoom in, and we can do the proximal end and the distal end. We can do those separate after that. So let's just turn it back this way and get the basic elements here, and then I'll go in more specific, right? Again, this is the largest bone of your body. I've always thought, I mean, you can think about that. Grab right there. That's like a hammer end. So if you had to defend yourself and you just happen to have a skeleton sitting there, would be a great bone to grab a hold of. It's strong as an ox. Beautiful end in which to pummel somebody. So this is a good one. You could use the other end as more of a blunt end if you want to do that, or you can do more of a pinpointed kind of percussion of the skull or something like that. I shouldn't be telling you this, but that's the way it is. So this is a great bone for something like that. But anyway, let's get back to the real stuff. So we have a number of features. Again, you can see that on the PowerPoint. The head, just the rounded head portion, right? We have the greater and lesser trochanters. Now, if you go back up to the humerus, we have very similar thing, but they weren't called the greater and lesser trochanters. They were the greater and lesser tubercles. But it's the same exact setup here on the femur. This side that you're seeing right here is the anterior side, right? This is the front of the leg. If I rotate it around, this now becomes the posterior side of the leg. Turn it right here. This giant area up here, this big bulge up here, that's the greater trochanter. The smaller bulge here that you see is the lesser trochanter. Okay? And then I'm going to rotate it back to the anterior side. Slide it down just a little bit. We have the distal end down here, the distal end, okay, flip it over to the posterior side, has these nice, smooth, articular surfaces, these huge surfaces here and here, right? Those are the femoral condyles. You can see them actually quite nice here and here. Those are the femoral condyles. They're rounded. Condyle means a rounded projection, right? They're a rounded projection where it allows the lower leg to go back and forth, basically slide in a nice fluid motion, the lower leg relative to the upper leg. So that's the knee joint, right? That's the knee joint area. So those are the condyles. And then, let's see if I can show. I'm going to zoom in on all this stuff here in just a few minutes. But between the condyles, there is an area between them that's sunken down. That's the intercondylar fossa. Intercondylar, it's between the two condyles, it's right in the middle, and it's a fossa. It's a depression, right? A fossa is a depression. intercondylar fossa. The intercondylar fossa being on the posterior side. So if we go back up here and we talk about the greater and lesser trochanters, right? If you remember from the humerus, the greater and lesser tubercles are on the anterior side. Down in the femur, the greater and lesser trochanters are actually on the posterior side, so it's opposite what you would have seen in the humerus, okay? So now let's zoom in and deal with the two ends separately, right? The proximal end, the distal end. Okay, very good here. Got the head, got the neck right here. There is that lesser trochanter here, right? See if I can turn it like that. Definitely see it beautifully right there. And the greater trochanter is just this big mess. All of this stuff up here, right? That's the greater trochanter. Okay. So if we were now to zip down to the distal end, okay, there are those condyles. Those now nice rounded condyles. You can see that nicely. Nice rounded condyles, right? Those are the femoral condyles. This is the anterior side. This smooth area here is the patellar surface. That's where the patella, which is your kneecap, that's where it sits. So we can bring it down and put your kneecap into the picture, right? So your kneecap sits right there. All right, so the condyles, and I rotate it to the posterior side, and there's that intercondylar fossa. This, you can see it really nice right there, right? It's a giant chasm right there, okay? That's the intercondylar fossa. Between the condyles, it's a fossa. That's always on the posterior side, clearly. Okay, so intercondylar fossa, posterior, patellar surface on the anterior, because the patella obviously articulates with that, and then going again back up to the femur, the head, greater trochanter, lesser trochanter, right? Okay, so that's the femur. So we can take that out of the picture, okay? Let's go now to the patella, the kneecap, okay? There it is right there. It's a very simple bone. There's nothing to it. I mean, if you want to look up all the little details of it, certainly there are lots of details on it, but not for us. I don't really care. As long as you know that this is a patella, right? The kneecap. That's the anterior side, the roughened side right there. You see the roughened area? The whole front of it there, the whole anterior side is roughened. So that's anterior. Remember, the posterior side of it articulates with the femur, right, with that patellar surface. So knowing that, you would all guess that the posterior side of the pelvis, or excuse me, the patella, is going to be smooth. Remember, because it's articulating with the distal end of the femur at the femoral condyles, right? So given that it's articulating with the femoral condyles, the condyles are smooth. In order for this to operate nicely in that position, also has to be nice and smooth right there for both of those condyles to sit like that. So the posterior side, flip it over, the anterior side, okay? This point right here is pointing toward the foot. So it sits in the body essentially like this. This would be then toward the foot end and toward the pelvic end right there. So that's the patella. I don't expect anything to be known beyond that. That's it. The patella is known, as I said this with the hyoid bone, is a sesamoid bone. S-E-S-A-M-O-I-D, a sesamoid bone. Now, if you recall back to the hyoid, sesamoid bones basically are free-floating bones, or bones that do not articulate directly with another bone. This thing is in just very general terms, it sits inside the tendon for the quad muscles, right? The quad's on the front of your upper leg, the big packet of muscles, right? connecting. Those muscles connect to a tendon. A tendon then goes across the, let me see if I can bring this back in. Okay, right? The tendon comes down, goes past the knee, and connects to the lower leg bone. Okay? And connects to the lower leg bone. So that when your leg is bent, let me zoom out a little bit more. Right? When your leg is bent like this, and you flex your leg to straighten it, it can be pulled up. The quads basically fire. The quads are up here, right? The quads fire, pulling this forward. They pull this bone to the front, which straightens your leg, okay? Which allows you, I mean, obviously, when you stand up, the quads have to have serious power to straighten that leg, thus lifting you off of the ground. Well, if I were to have just the tendon alone going across the femoral condyles, going down to the lower leg bone, if I were just to have that tendon by itself going across, you would not have enough, even though your quads are huge, would not have enough power in order to straighten the leg to get you up off the ground. What it's going to require is an element that we call in physics the fulcrum point, right? So we need an extension of that area. It's kind of like a pulley system, you know? You put a bunch of pulleys together and all of a sudden you can lift 1,000 pounds. But if you tried to just pull it up over one single pulley, you couldn't lift it off the ground. But put the rope through several pulleys and all of a sudden the thing comes up with minimal effort. It's the same exact thing. The patella sits inside of that tendon. It sits inside the tendon. That's why it's a sesamoid bone, right? It sits in the tendon. And that's what gives that extra fulcrum point. It gives that extra power for those quad muscles to pull the lower leg up and to straighten the leg, allowing you to lift yourself off the ground. That is a huge, a seriously important bone when it comes to doing what we do. Now, the reason why we can move it, you can reach down when you stand up, lock your legs, and then you can sit there and wiggle your kneecap all over the place. The reason why is because it's just sitting in that tendon. As long as you don't have your quads firing, which means your legs are straight, the knees are locked, your quads are not firing, they're very loose, right? That means the tendon is not under any pressure, so you can just grab the kneecap and just move it all around as the tendon is vibrating. I mean, obviously you can't go up and down the body, that would be awkward, but you can go back and forth a lot. But then unlock the knees, get the quads firing, all of a sudden that tendon has tension on it, and this doesn't move anymore. This is going to be a critical element. But when you're straight-legged, you can move that thing all over the place. A very difficult bone to break, though it can happen. I mean, when you land on your knees, you land on the patella, so if you do it hard enough, you can break it. But the fact that it moves around means that it's going to be a little harder to break. But it can be done, but it's rare. It's rare. Okay, so that's the patella. Now we go into the lower leg. Alright, so the lower leg is composed of two bones, kind of like the forearm, right? So we go back up to the arms. We have the humerus, which is the corresponding bone in the leg, the femur, right? So it's the corresponding one of those. Then we go back up to the arm and we have the radius and the ulna, the two bones of the forearm. You go down to the lower legs and the corresponding bones would be the tibia and the fibula. Okay, so those are the two bones. We have two bones in the lower leg, we have two bones in the lower arm, if you will, or the forearm, right? So let's start with the first one. Again, looking at your PowerPoint, I'm just going to show you the whole thing real quick, and then we'll go in very specific to the proximal end and the distal end. Okay, so that's the tibia. Some people remember tibia by, let me see if I can make it like that. Some people have remembered it this way, that it looks like a T. It has a T look to it. I mean, I can see it. Well, that's kind of like that. It's kind of a T look, right? T look, tibia. I don't know if that works for you, that works for you, okay? So we have the tibia here, we have the proximal end down here, we have the distal end down here. Remember that tendon that's attached to the lower leg that was coming off those quads. That point of attachment is right here. It's toward the proximal end. So when it pulls this direction, it pulls the leg up. Pulls it up. Attaches very high. You'd have a lot more power of lifting that leg if it attached further down, right? That would really allow you to pull up. It actually attaches way up here, which means you have to have that extra power, meaning that extra element, i.e. the patella, to give that longer range of motion. You know, when we're talking about physics, when we're talking about range of motion, we're talking about being able to pull that lower leg up. Okay, so that area right there where that tendon attaches, that's called the tibial tuberosity. Okay, tibial tuberosity. Zip down to the distal end and you see this portion projecting off the bottom right there. That's the medial malleolus. Okay, why they have all these weird names, I don't know. Because if you go back up to, let's say, the humerus, we have a bulge, not exactly like that, but we do have a bulge off the one side that we call the medial epicondyle, and this is the medial malleolus. So it's not quite the same. I mean, it's a different unit. It's a different style of element, but it doesn't matter. It's still kind of awkward that we'd have so many names for everything. Okay, so let me turn it and let me zoom in on the proximal end. Okay, so there's the proximal end. There's the area right here that we call the tibial tuberosity, that bulged area right there. Kind of hard to see, but all of this extension is the tibial tuberosity. That's again where the tendon attaches coming off the quads, right? Let me see if I can pull this up. Yeah, I don't think it's going to work. But there are kind of these smooth areas here and here, right? Yeah, kind of, right? Here and here. Those are the areas that articulate with the femoral condyles. That's the other side. So the condyles are kind of semicircular, smooth bulges. They articulate with those two right there. This thing right here sits inside the intercondylar fossa. So this goes in that groove that I showed you just a little while ago. And there is the tibial tuberosity right there. All right, so now let's go down to the distal end. And there's the distal end, right? Okay, that's the medial malleolus right there, sticking down, right there. That's the medial malleolus. You notice that the end here, the distal, very distal end is smooth. That's a smooth surface. Let's see if we can get the camera to kind of, there you go. So that's a smooth surface right there. That is the end of the bone, the area of the bone that articulates with the ankle bones to essentially make that ankle area. This right here allows the foot to go up and down. It allows it to slide up, slide down, and make that movement right there. And then, of course, we have this little notch on the side here. Hard to see maybe. What we call the fibular notch, because that is going to articulate with the fibula, which is on the other side. Okay, so if this is the medial malleolus, right, and by the way, if you reach down to your ankle, right, and you have two bumps just at the very ends of your lower legs, you have a bump right at the top of your foot, right at the top of your ankle, and a bump on the other side, so you have these two bulges. The one on the inside of your lower leg, right down by your ankle, the one on the inside there, that big bulge, that's actually that right there. You're actually feeling that part right there. The bump on the opposite side is created by the second bone, right? The fibula comes down like that and creates the other side of this, I guess, what U-shaped joint, right? So that bump that you feel on the outside, the lateral side, would be the distal end of this. There are your two bulges basically like that. Right? Okay, so medial malleolus means it must point medially, which basically allows you to side this thing. You guys aren't going to have to side it, obviously, but that would be a great way of siding it. Put it on the medial side, put the tibial tuberosity on the anterior side, which it has to be. Again, if the quads are attached to it, that has to be on the anterior side, and you're done. Okay, you've sided this thing. Beautiful, beautiful. All right, so let's now jump to the fibula, right? The fibula is the last bone of the lower leg. This would be corresponding to the radius. Okay, so this would be essentially the radius from the upper arm. The tibia would have been, let's move this, would have been essentially the ulna, right? Because remember, the ulna is on the medial side of the forearm. The radius is on the lateral side of the forearm. If you look down in the lower leg, the tibia is on the medial side of the leg, just like the ulna was. The fibula is on the lateral side of the lower leg, just like the radius is on the lateral side of the forearm. So this one corresponds to the radius, this one corresponds to the ulna. Okay. The radius, it's a simple bone. There are ways of identifying rights and lefts and all that kind of stuff. There are features on it, but I got to be honest, I don't really care about any of the features. As long as you know what a fibula is, we're good. We're good to go. Look at the size. So I don't have like a scale, I guess, but I have my trusty pen. You can see the fibula is very small. I mean, it's long, but it's very small in general, like diameter, you could say. I mean, relative to the tibia, I mean, this is just gross how big the tibia is to the fibula. So the fibula is a nice thin bone. It's a very straight bone, but it is long, right? I mean, my hand there as a guide to the general size of it, right? So that is like to my wrist all the way up. So it is a very, we can slide it down, it's a very long bone, right? Well, it's the whole length of your lower leg. So it is long bone, but it is very skinny. So that's the fibula. Remember, the distal end of the fibula is what makes the, let me see, makes up that lateral side of the ankle, right? Let's see if I can stand it up. The lateral side of that ankle joint, that U joint, I'm trying to hold these together. Makes that U joint like that. Remember, that distal end of the fibula is that outer bump. It's the outer bump you feel on the lateral side, but it creates that U right there. Now, what's the U do? That takes us right to the last element, which is the foot. Let me show you the foot, and then I'll show you how that U shape plays out, what its job is right there and how it operates. Okay, so now we're finally to the foot. Very easy. It's just like the hand. I'm not going to require that you know all of the bones of the foot. If you go back to your hand and wrist area, if you remember, you have carpals, metacarpals, and phalanges. With the foot, we don't have the carpals. What we have are tarsals, right? Again, this is on the PowerPoint. So you think about tarsal, and instead of metacarpal, we have metatarsals. Just think T for toe. So tarsals, toes, foot. Metatarsals, toe, the T, tarsal, toe, the foot. The carpals, metacarpals, that doesn't help you at all because there's nothing really to say up there. Carpal hand doesn't make any sense, or carpal finger. But down here it does. Think of the T for toes, right? So we have the same kind of system down here. We have a series of bones that make up the ankle, if you will, but a big portion of this is actually stabilized. It's not really like a wrist. Your wrist can move in all different directions. this part of the foot, kind of the posterior end of the foot, these tarsals, they don't really move. They don't really do a whole lot. They flex when your foot is shoved to the ground, so they kind of move on one another, but they don't allow this high degree of flexibility like your wrist is. Which makes good sense, because if it were highly flexible, it would be much more difficult to walk on two legs when you had an ankle that was very movable. Essentially, your ankle is, you can move it a little side to side, but mostly it's the up and down. And the up and down is not accomplished by way of the tarsals. It's actually accomplished by way of, flip it around, this surface right here. This bone, this single bone up here, okay? This bone up here, having that smooth rounded projection, that's actually the joint. That's where the U shape from the tibia fibula combination, that U shape sits right on here. It basically sits, let me rotate it this way. That U shape essentially sits right on each side here. And this surface is the surface that touches that smooth surface I showed you, the distal end of the tibia, right? So the U shape sits on both sides, the tibia then sits right on top, and since this is a rounded projection, right? It's rounded, it allows the foot to go up and down like this. It actually slides on the bottom of the tibia, and the tibia fibular combination, that U shape, or better yet, we could say the distal end of the fibula and the medial malleolus, those make up that U shape that goes around. Now, I could attempt to show you this, and I will, but it's going to be ugly because it's hard to hold all these bones simultaneously. So I can actually just hold the tibia up here. So I take it off. There's the medial malleolus, right? There's that smooth area right there. Go back down onto the foot. Goes just like that, right? Just like that. And allows the bones to rock back and forth on one another. Just like that. That's what gives that ankle joint the ability to lift your foot up and down. But there's not a whole lot of wiggle either way, because you actually end up with this, that U shape that I was telling you about. You end up with, it's impossible to hold all this stuff together, but that U shape, right? The other side of this articulating with that side, yeah, this is going to be impossible to really do all of it. But that U shape slides up and down like this, right? Well, that's gonna, but the medial malleolus on the one side is holding the ankle there from going back and forth, and the fibula sitting on the other side, right, keeps it from twisting that way. So between the two, they create that nice U shape that sits on both sides. You can see that. See the smooth side right here, and see the smooth side over here. It's because the U shape is sliding on that. But again, it keeps you from making that move. And of course, that's why when you roll your ankle and you twist it hard out of that U shape, there's major damage down there, because it's not meant to do that, clearly. Your wrist is a little different. It's allowed to go in just about every direction you can imagine, but not the ankle. It's got to stay secure. It's got to stay secure. That makes perfect sense, if you ask me anyway. All right, so move those off. Getting back to the foot. So we have the tarsals, right? Okay. So we have the tarsals. Now, unlike the carpals, we have 8 of them. When it comes to the tarsals, we have 7 of them. So they are, carpals and tarsals are the kind of, they're the same grouping, but you have 8 carpals, 7 tarsals. All right, but then if we move up, we have 1, 2, 3, 4, 5 metatarsals, just like we have 5 metacarpals. And then we get all the way down to the end, and we have all those phalanges. Now, It is just like in the hand, just like in the hand. Pinky toe all the way up to the big toe, right? But the pinky toe and the other four or other three of the toes here, so the four, what I call toes, I guess, they all have 3 phalanges each, just like in the fingers, but just also like in the thumb of the hand, there are only 2 phalanges in the big toe. So 2 phalanges in the big toe, just like 2 phalanges in the thumb, and then 3 phalanges in each of the other toes. So how many total phalanges do we have in each foot? Well, again, 4 times 3 is 12, plus the 2 that are in the big toe, we have 14. So we have 14 phalanges in each hand and 14 phalanges in each foot. Okay, so the phalanges, the metatarsals, and the tarsals. Okay, this right here, let me twist it around for you. This big giant bone down here, this is all one giant bone, that whole thing, right? This is the heel. This is your heel. It's partly what keeps the foot, obviously, when it hits the ground, it gives it that base, right? So this is the ground here. It gives it something nice and hard to land on in the back, but it's also what keeps it from rolling side to side. So when you're running, you don't roll your ankle every 5 seconds. That big bone in the back gives that stable rear version, posterior version of the foot, but also stabilizes the roll. So it's pretty cool. But again, I'm not going to ask you to know all the bones of what I'm calling the ankle, which it's really not. As you all know, the ankle is really just this bone here and the distal end of the tibia and fibula. None of this stuff moves anymore. This is actually part of the middle part of your foot. This is the heel back here. So I don't know about calling it the ankle, but in essence, if we're going to create a corresponding or think about the corresponding area of the body, you would say that would be the wrist. So yeah, the ankle region, the wrist region, you know how it is. Okay, so that is the foot. And that concludes the entire skeleton. We've gone through the skull. We did that a while ago. We went through the axillary skeleton, basically all of the trunk region. So that would be the vertebrae, the ribs, and the sternum. Then we went into the pectoral girdle, which is the scapula and the clavicle. Then we went into the pectoral limb, which would be the humerus, the radius, the ulna, and the hand. Then we moved down today. We moved down into the pelvic girdle, which is the innominate. Each innominate made up of 3 bones, remember, the ilium, the ischium, and the pubis or pubic, right? So on each side, the sacrum completes the pelvis, but is not considered part of the pelvic girdle. Then we moved into the pelvic limb, which is the femur, the patella, the tibia, the fibula, and the foot. Okay, so that concludes the entire skeleton, top to bottom. If we were in class, I would have made you side each of these bones. You would have to know, is that a right tibia or a left tibia? Is that a right femur or a left femur? I would have done that to you, but thankfully, I guess for you right now, I can't do that two-dimensionally on a video, on a test where I can just put pictures up. I can't do that to you, so you lucked out in that regard. But I wish I could have had the chance to actually teach you all of these things. It's not to be mean. It would be more so that you understand how to lay out a skeleton. A skeleton in a forensic context, you have to lay out the entire skeleton. We talked about this at the very beginning of the semester, close to the beginning. Lay out the entire skeleton, put it in anatomically correct position, which means on the back with the thumbs pointing laterally, pointing out to the side. That's correct anatomical position, right? Lay it out on the table. Why? Because we have to know what we're missing. So I need to know, if I'm missing bones, am I missing a right tibia? I don't know. Well, let's see. Do I have the left tibia? Oh, yes, I do, but I don't have the right. Perfect. So knowing which bones are missing is critical. So we are losing that by not being in class. You guys won't be able to do that. Again, remember what I said before. What if you're missing like some of the phalanges and maybe the ring finger on the left hand? That might be kind of important to know that that one is the one that's missing. I'm missing a finger. Okay, well, which finger? Well, it's good to know. Ah, that was the ring finger, so that may indicate some kind of angered spouse of some sort. So having all this stuff all laid out, knowing what is there, what is missing, makes a big difference. So I kind of wish I was able to show you how to do this. Just for that purpose alone. It does make it more difficult when it comes to learning material and being tested on, and it would have made it more difficult for you, but at the same time, it's about education. It's about teaching you this stuff. It's about you understanding the process, understanding how it's done, giving you the tools, and I'm just not able to do that by way of video. I did a little test video to see if I could try to get you to understand or see on a two-dimensional video, is that a right or a left this, a right or a left that, and it just came out, there's just no way for you to actually be able to do it two-dimensionally on a video or on a picture. It could be done, absolutely could be done, but it also would have been very challenging for you to do. So yeah, it's unfortunate you are missing out on that. But otherwise, you know every bone in the skeleton. You have that all laid out. The next thing on our list of activities, of things to learn, will be how to do what we've been waiting for forever, the demographics. How do we know if it is a male or a female? How do we know if it's a young person or an older person? How do we know if they are of European descent, African descent, Asian descent? How do we know that? How do we know how tall they were? How do we know if they had any pathological conditions, diseases, markers of occupation and all that kind of stuff? That's the stuff that's what we've been waiting for, because that's what we're going to write our report on when we send it off to the police. We're going to give them this description. And the description is then going to be used to narrow a database, and the database then, whatever's left, will then be researched by detectives or whomever does any of those kinds of things, right? They're going to then go after that stuff. So we've been waiting this entire time. As far as class goes, we've been waiting for this moment, this time. It's going to be enjoyable. You're going to find it's cool to see, oh, that's the difference between a male and a female. Oh, that's the difference between a person that is young and that is old and all that kind of stuff. It's the fun part. Again, it would have been nice to do it in person, but we've got to do what we've got to do. So I'm going to do my darndest to teach you all this stuff. But that will be next time.